Great. Hi, everybody. And I'm here because I'm the moderator. So I'll get us going, and I'll periodically come up and introduce other people. And then at the end, I'll give you a summary that you can take back home to people about what the conference was like. And I appreciate you being invited here. It's been a really exciting conference so far. As was mentioned, we do have 4 presenters talking about emerging models of healthcare delivery. The setup is they will have about 15 minutes to talk and 5 minutes to field your questions, or if they talk for 10 minutes, and they can have 10 minutes to field your questions. And then we will be done at, let's see, 20, 46, 80 minutes from now, and we'll have the rest of the time for discussion. I really want to encourage the people in the audience who are here from programs and program systems to ask questions. This is really your chance. You don't want it to be the kind of thing you go back and say, oh, I was there, but I really didn't get to ask them questions or make my comments. So I want to encourage you, write things down that you'd like to ask these people about and raise them when the time comes. So our first speaker is Terry Horton. And Terry is a really interesting guy. I've heard him speak at several places, and probably so have you. He's at the Christiana Care program, where they embed substance abuse, in terms of a model of service delivery. They embed substance abuse counselors in primary care programs. But Terry also thinks about how to organize things and how to do things in a way that will meet the needs of the care system you're working with, so that his services will be in demand. So Terry Horton, take it away.
Thank you. So I'm an internist. You should know that. I work in a health system called Christiana Care Health Systems in Wilmington, Delaware. It's the primary health system for that neck of the woods. So if you have the misfortune of an accident on your way to Philadelphia from here, I'll see you. I'm an internist, but I have this other role as well at Christiana. I teach residents and I see patients in primary care clinic and in the inpatient setting. And I was also the medical director for Phoenix House for 15 years in the therapeutic community. We set up on-site, actually we had a very large on-site primary care system within that world. So I come with that perspective, which is to say I worked with people in recovery every day and learned a terrific value from them and many, many lessons. So I try to share some of that with you around Project Engage, which is the program that one of several that we've implemented in Christiana. But first, a little bit of background information. I think that's really important, and I'm really going to focus on the hospital. And the reason I'm going to focus on the hospital is because that's one of the portals of entry for people that we care for. Hospitals and jail, right? 2 places that aggregate highly disordered individuals, neither by their desire, but they end up there, and often in crisis. And so in that hospital, by hospital, I'm referring to the inpatient, medical, and surgical floors. I'm not talking really about the psychiatric floor, because I'm not a psychiatrist, but the medical floor. So if you have pneumonia or a heart attack or kidney failure or any of those kind of things, you end up in a hospital. And on those medical floors, there are fairly high rates of alcohol and substance abuse amongst the patients. We've heard about the emergency rooms. We know emergency rooms and trauma have really, really high rates as well. And not only are there high rates, but and this is using the lingo, DSM-4 lingo, but there's certainly high levels of severity for alcohol use disorders. Very dependent. And Richard cites and his group found 77% in some of their studies in Boston. And I would say that's our experience. And many hospitals have very similar. So they're not just folks that are drinking, but they're drinking a lot. And it's harmful. And not just because they tend to be older, they tend to have a lot of time doing these disordered behaviors. They're not very compliant with their health issues. And they've acquired quite a lot of comorbidity. So they're sick. You don't get into the hospital these days unless you're really sick. And they're really sick. They also are wickedly expensive. And they, addiction is a disorder of motivation, and these motivational circuits and judgment. And, they don't, so you may have pneumonia and you're supposed to take your antibiotics upon discharge from the hospital, but you probably won't. And so we see, or you may leave really early because for a number of different reasons. So they don't complete treatment, they don't enter into primary care, and we enter this revolving door that we've known that this is not revolutionary stuff. This has been going on for decades. Problem is, it's really been addressed in a hospital system almost as sort of, this is the nature of things. This is what we attend. This is how things are almost to be expected. And not liked, that revolving door, but it's business as usual. That's how I would describe it. And when I came to Christiana back in 2007, after a long hiatus away from organized medicine, I was working in Phoenix House, that's how it was felt. Like these patients was business as usual. Well, let me just shift gears just a little bit. I mean, so you walk into this health system and it's business as usual. Everybody's kind of depressed by these patients. They're demoralized by these patients. And they really don't want to take care of these patients. There's almost a clinical utility that you see in the setting. And you come in and you want to change something. It's not enough to have a good idea. You really have to understand how things are adapted and adopted in those kind of health systems. There are thousands of great ideas that bubble up. The people that work at Christiana, like most hospitals, want to provide good care. Lots of good ideas bubbling to this top, but not all those good ideas are going to get acted on. So just as you are being trained to meet your patients where they are, you're going to meet your health system where it's at. It's sort of like organizational, motivational interviewing. And that's really important. And you've got to find your opportunities to be heard amongst all those bubbles going up, that things that really do matter to the people who are making the decisions. And I'll just list those in a moment, and you'll see. And I've tried with Project Engage to, at least we have succeeded and are on the way to meeting some of these areas. And it's really around the issue of creating value. I mean, I almost hate that word. It's like one of those cliches that just torments me when I hear people speak about value at Christiana. And we've had a Value Institute, which is basically our outcome study group. Yeah, but don't ever ignore that, because that's the group. If you don't have value, you're done. Your history, you're gone. Your office gets used by someone else. So value is important, and how you define value, and half of my mission is trying to, it's really easy if you're taking care of kids with cancer. It's really easy. The value's obvious. It's hard when your parents or your patients are warty and not well liked. So but nonetheless, our mission is to create value. Our patients we have to help the health system understand the value of properly caring for our patients. That's a new, and one of the challenges when we were at the steering committee at NIDA a week ago, you heard everybody going on and on and on about these really interesting and well done clinical trials. But nearly none of those clinical trials would be viewed in that, we call it the C-suite, which is the suite of leaders at the hospital actually make things happen. They wouldn't really think of those things as having much value. Stride, for example, interesting, not much value. Or not enough value to shunt money from something else that has value. Do I make my point clear? Value. So I should actually make this slide say value. And certainly value, fiscal, hey, this is a reality. There are narrow margins, and where the cost of doing business was accepted in the past, it's not now, because there are narrow margins. And our population is identified as overutilizing and underinsured. The underinsured is being addressed. That's no longer a disadvantage. This is actually an opportunity, because making our hospital aware of their associated cost, opportunity, because we can start to say by interventions we can actually, so what I'm really suggesting is you don't even need necessarily to have a model that is dependent on revenue, though I can tell you right now, I wish I could say I had that model, because that would ensure my survival. But there is this other opportunity to define your value by what you can save in the system. Because in a moment you'll hear that cost savings and shared savings are actually an opportunity that the hospitals and health systems are going to be utilizing. Everyone heard of accountable care organizations? Probably, some of you probably have, some of you probably haven't. With ACA 2010, Obamacare, and some of the things that Tom talked about yesterday, there's a fundamental way in which reimbursement is being reorganized. Systems of care now are going to be given pots of money to take care of populations of people. And what's the lovely fact is that 10% of any of those populations have what issue? And oh my God, they're a disordered population that you can't ignore. That's our mission. Because if you can't ignore them, then they're going to say, the next question is, well, how do I take care of them? So if we can come up with methods to attend to that, it really is a terrific opportunity. Who's heard of value-based purchasing? Raise your hand if you've heard of value-based purchasing. Wow, this needs to change because that's a minimal number of you know about this. In a hospital, this is nearly quintessentially important. Value-based purchasing means that my hospital is on the hook for $50 million to lose by 2017, or to retain $50 million. Now, Christiana's a big hospital. We're not that big to lose $50 million. What that means is, so right now, value-based purchasing is around Medicaid revenue. So we bill Medicare, and to the tune, I think it was somewhere like $100 million. And we get revenue. And now, with Obamacare, after 2010, we are at risk for losing 3% of that, 2% of that, if we don't meet certain performance indicators around readmissions for certain diseases. But that's actually ratcheting up. It's going up to 3%, and then they're adding other things. The other things they're adding is outcomes. So if our 30-day mortality rate goes over a threshold, we're going to start losing more money. It's almost like they're taking money back, and then you can get it back if you need it. It's not completely clear. 30-day readmissions and patient satisfaction. So that's measured currently with 48 hours to 2 weeks after you're admitted to the hospital, and you leave the hospital, they send you a query, Prescani usually, and you fill it out. And it matters hugely because a quarter, 25% of my hospital's value-based purchasing dollars are tied to those scores. And there's something called the 5-star tier, which is the quintessentially perfect place to be for a hospital. The highest level of patient satisfaction and performance. And it's going to be sought after, not only because you get to keep your money, but because it's pretty very prestigious. Well, do you think that our patients could adversely affect the likelihood of my hospital getting into that 5-tier? Do you think the patient what do you think the patient satisfaction scores of heroin addicts coming into the hospital whose detox regimen doesn't really meet muster? Anybody think their hospital right now would have a 90% patient satisfaction survey from their substance use disordered patients? No? I don't think so either, and I think that and we don't even know what this is. It's an area of opportunity that we're going to be trying to look into. But you get the flavor of what I'm saying. Our population, and if you can figure out ways in which you can improve this for your hospital system, golden. And so that's, in that world, value is created. Safety. In my hospital, safety really, really matters. And it was our entree, actually, to develop, in 2007, our first substance abuse infrastructure. There was none prior to that. You could get your prostate out by a robot, but you couldn't get any kind of drug treatment. It's true. Safety mattered because there were 3 root cause analyses from patients who had DTs that were poorly managed or not even acknowledged. One tried to pull a nurse through the 5th floor window of the hospital. One in the ER hung himself in the pediatric waiting room. And one nosedived off of a gurney in the ER and was a vegetable. I mean, these are horrible things. All of them because of systems of care that were really not up to snuff around alcohol withdrawal. And so that was a wonderful opportunity for us because the hospital said, do something, change this. And we implemented alcohol, a really comprehensive, we use actually the audit PC, which actually we've shown to be able to predict withdrawal. And Anna actually is in the room who wrote that article, who was the lead author, with George Woody and myself and Ed Ewing. But safety was the critical piece. So we ended up, I want to make sure you understand that. Staff morale is a critical thing as well. So staff morale is quintessentially important. My staff do not have good morale about our patient, not my staff of the program, but in the hospital. So let me just tell you briefly about Project Engage. It's a peer counselor-driven process. We embed our counselors from the drug treatment program for anyone counseling into our hospital. These peer counselors, basically the process works. A nurse, it's really ERT or BERT. There's no screening. These people are self-identified. Why it matters, I mean, I know Rich very eloquently told us about why some of these systems don't work around SBIRT, or at least, and it makes sense for these highly dependent individuals. You know, a 10, 15-minute conversation does not cause an epiphany. However, Bertha Lay and others said, well, gosh, but if you can get that person into treatment, you can make some impact. So that's really essentially what we try to do. We try to use peer counselors, and they use early engagement strategies, and they use motivational interviewing, try to meet the patient where they're at, and help transition them into care, transition them into whatever care they're willing to take. And it's a very intriguing process. Our social workers are there as content experts. It's easy to talk to somebody. Most of the patients that we meet who are referred to us by the nurses, primarily nurses, are very amenable to our getting into care. But then come the barriers and our social work.
Just so you know, you're into discussion time now.
Oh, okay. Sorry. I thought I was going to... last piece I want to make sure that you understand is that we use a concierge model. For adoption, what am I talking about? Well, I tell my staff that their customer is not the drug addict in front of them. It's the nurse who referred. Because providing that nursing support is everything. And so or the doctor. And so being able to help, and that's helped us with adoption. Just give you a picture of my team: pipe fitter, social worker, ex-ad executive, ex-owner of McDonald's. Just briefly, we've seen about 2,500 individuals, 29% from the inpatient unit have gone on into care, 20% from the ED. By the way, the ED is much more cold calling. There are not these relationships with the nurses to ask, the patients. They just tell us, hey, one over there, and or we go hunt the patients down. And we've been able to get actually only 10% of people refuse to talk to us. It's actually really interesting. And we've been able to have a 38%, when we compare 6 months before, 6 months after intervention, both from a study from our insurer as well as from our finance department, showed reduction in inpatient admissions to the tune of $6,000 per patient, which matters. And when we look at people who get into drug treatment compared to those who don't, if we park your butt over in a drug treatment program, you're not over here. And you have reduced, so up to the tune of 38% reduction in readmissions. Again, getting back to those metrics that the hospital cares about. We had a nursing attitude study where the nurses, we actually showed pre and post exposure to our counselors. Nurses, the demoralized nursing service, felt that they had more confidence in SBIRT, more confidence in their ability to intervene with, and were generally more hopeful about dealing with these patients. And we actually reduced falls, or we think we're reducing falls in the emergency room, because 29% of falls, a major safety metric, is caused by intoxication. So our guys got trained up by the ER staff and are an extra eyes and ears for
what this was going to go like. And Jim's stuff was very interesting about how he tried some models, and then finally he's learned how to do it well. So I really look forward to hearing about this model of enrichment care from Jim May of the Richmond Behavioral Health Authority.
Thank you very much. What the program that I'm going to talk to you about today is a grant-funded project at the present time, funded by SAMHSA, so I want to say thank you to SAMHSA very much for allowing us to do this. I'm a psychologist by training, but somebody turned me into an administrator and a planner about 20 years ago, and so I do a lot more of that now than I do what I was trained to do, so some of this I just stumble upon as I go along. Some people have called me a long-term non-recovering workaholic, and so I'll just put that out front. I have no financial conflicts to disclose. All of my conflicts are psychosocial in nature. Most of them involve my mother, and I don't want to talk about it. So, this is a grant-funded project, and for the last 20 years, one of the things that I've been able to do at our agency is to try to use grant funds to start new programs, new services, to rearrange things at our agency. Richmond Behavioral Health Authority is one of the 40 community services boards that covers the Commonwealth of Virginia. We're the only one, the Code of Virginia allows for 4 different organizational categories. We're the only one that have elected to be a behavioral health authority at this point in time. It's a quasi-government status, gives us a lot of autonomy, which is great. And so people like me get to choose what we're going to do next. And so one of the things that we've been thinking about a lot is integrated care. And about 2 years ago, we decided we'd start going after grant funds to get further along with integrated care. 2 years prior to that, we had engaged in a relationship with a local FQHC on a very small project that was funded by the Virginia Healthcare Foundation that specifically had one of the nurse practitioners from the FQHC come to our building to start delivering some primary care services to the most seriously mentally ill folks, and at the time that did not include people with substance use disorders. That was a 4-year grant, and when they got near the end of the 4-year grant, they realized that they hadn't met their targets for numbers of people to be served. They called some of us into the project to say, let's take a look at this, and we realized that it was kind of an invitation-only selection process for which consumers of ours got to see the nurse practitioner. And at the waning months of that grant, they started inviting the folks with substance use disorders and some other people around our building to come on down and get services. So, as Jim said, we did learn some lessons from the previous project. There were a couple of other lessons that we learned that are as important as anything else I'm going to tell you about today, but after doing that for 4 years, we had absolutely nothing in our medical records to indicate that these folks had gotten these medical services, other than there was a note that they had been referred to the clinic. The electronic health records used by the FQHC did not communicate with the electronic health records that we were using, and vice versa, and we basically had to beg to get copies of any kind of paperwork that would, and it would be paperwork, it would not be electronic, from the FQHC about what we were doing. So there were some decisions made as we started going after some bigger grant funds that we were going to try to do this differently, and that's what I want to tell you about where we are today. A little bit of background. Richmond, not unlike Baltimore, has a lot of the East Coast high-density urban area diseases. The 2 that stand out the most, we're most proud of, is WebMD said Richmond is absolutely the worst place to live if you have asthma. I have asthma, so I can attest that that is absolutely true. And we were rated as the 2nd fattest city in America. So we have 2 things that we're very, very proud of. There's a whole list of things that Richmond adults suffer from, and the reason I'm focusing on adults is because our grant currently is focused on adults. We're not dipping into children. That wasn't really allowed under the grant, but that's in a long-term plan for us, because we do serve kids at our agency as well. But all of these indicators for Richmond adults, the interesting thing is that the people that we serve with serious substance use disorders, serious mental illness, and intellectual disabilities are worse on all these categories than the general population. So that's what we're trying to fix. We're going to try to get started with this. We have a $1.6 million grant from SAMHSA, and what was a small closet in a far-reaching part of the building for the New Lease on Life project, we said that was a mistake. This needs to be a highlighted program. we used some initial grant funds to renovate part of what is already the psychiatric clinic in our building. So you walk into a waiting area, you've got the psychiatrist down this hall, we have a pharmacy to the right over here, and the nursing station's back there. So right behind the nursing station, we've just reconfigured 3 offices, 2 of which are now exam rooms, and the other one is the office for the physician and nurse practitioner. And we've actually enrolled the first 50 clients. We just got started with this grant the previous quarter. And I think, I see Neil in the back. Did we get the certificate of occupancy or whatever we were waiting for last week? Yeah, well, we had one more official review before we could actually start using the facilities, but I think we did get that last week. So again, the target population is serious mental illness and substance use disorders. And we literally have a plan for how we're going to bring them in. We've identified unit by unit. We're going to bring in clients from this unit first, then this unit, and this unit while we're building up to capacity. I think that from the very beginning, one of the other things we said we were going to do differently this time is rather than have 1 or 2 people in the building know about the project and implement the project, we were going cross-agency. So we have a fairly large planning team. There's about 12 people on it to go across all the divisions of the organization. Reasonably high-level people, including myself, and we have what I would surely call unambiguous and unqualified support of the CEO of the organization. He is our lead marketing officer at this point for this project. He's a cheerleader in public venues whenever he has a chance to speak, and he does so internally as well. So we're all benefiting from that support from the top, and I think that's essential if you're going to be successful. I'll talk about the model we fell upon in a minute, but we also said right at the beginning, and we had learned this from other grantees that we had heard, that you're not going to make this work unless you can figure out how to do the billing. We heard a couple of allusions to that yesterday, but I'm here to tell you right now, I understand my job is I got 3.5 years left to figure out how to pay for all this stuff. When the grant funds are gone, there won't be any other funds to use to support this that I can see in the immediate future. And we're also making sure that everybody has got buy-in internally and externally with a lot of marketing. The little picture here, when we were selecting the people to sit on this planning team, we kind of asked ourselves a question: who's capable of swimming in different waters? Because that's really where we're going right now. These are people that need to be able to be flexible, think outside of their usual boxes, and I think we've succeeded in that. And then another piece that didn't get mentioned a whole lot yesterday is a requirement of the grant, so we have to do this, but it's a pretty important piece of the healthcare delivery system under the Affordable Care Act, is this whole notion of health registries. They want to start keeping track of, people with all these chronic diseases. We like that slide so much we put it in there twice. So we are looking at these top 2 quadrants. Everybody in here has probably seen these. If you haven't, this is something that's worth taking a look at. But as the healthcare system gets shaken out, we're looking at the people who have high behavioral health needs and who also have primary care needs. Those Quadrant 2 and Quadrant 4, that's who we're already serving in our agency. Give you a little bit of a scope of that. 2 years ago, with a slightly bigger budget, we served about 11,000 people, and last year we were just under 10,000 with about a 10% budget reduction that we had gone through the previous year. So we're serving 5% of the city's population. That's not an insignificant number of people. And the other thing I want to say is that the people we're serving, these are the people who go to the emergency room on Friday nights if their child has a cold or if they have a cough. They don't go to primary care doctors. They can't tell you, most of them, who they are. We did a survey of our clients several years ago and asked them, and a little less than half said they did, and then we followed up and said, do you know that their name or where the office is, and they don't have a clue, or how long it's been since you've seen them. So they're not good utilizers of the healthcare system. So launch and sustainability have been on our radar ever since we started. We started with the newsletters internally within our organization right off the bat. We've got buttons that look like the little icon you see up at the top right here that we started handing out for staff to wear all over the building. We must have 26 or 28 different service teams throughout our building, and they all meet, separately, have their team meetings. We went to every single team meeting in the building for at least an hour with information about this grant and to field any questions that anybody had to start to build the buzz, and it has worked. We are in the process of revamping our website, and you're going to see the primary care clinic take on some major importance in the website. We have some plans for social media once we've actually done the launch. The launch events are scheduled for the second week of April, and we expect to we're going to invite the governor. We don't know if he's going to come, but we are going to invite the Secretary of Health and Human Resources. We do expect he's going to come. Virginia, right now, we don't have either a Commissioner of Behavioral Health or a Commissioner of Health, but if they're announced before then, we'll invite them too. Otherwise, we'll invite their interims in the meantime. One of the teams, the work groups that we set up, their whole job is to figure out the billing piece. So we're relatively new into our own EHR system, and as soon as, of course, we got that set up, I went out and got this grant, and then they said, wait a minute, there's nothing on here about billing for primary medical care. So fortunately, we have a very motivated EHR team. They used to be called the core team. Now they're the change team, but this is a big piece of the change that they're working on. And they're literally, I don't know if you've ever seen these, those of you in the medical professions know this, but these super bills, which are the smallest fonts that you can fit on a page that itemize like every possible medical service that you could ever provide anybody, so that docs can just check off things that they've done with each person that they've seen. And we're literally building a code in our billing system for every one of those things that we would ever reasonably do. We're not going to fix broken arms at the clinic, but all the other things that we might do. And we've already identified we're going to bring in a billing consultant to make sure we've got all that set up correctly. So bill is where we're heading for that. I'm happy to entertain any questions for you. As I said, we've had 50 consumers enrolled already. We have brought in an existing research and evaluation team that cuts across the whole organization. I have two of those folks in the back of the room. If you want to raise your hands, Amy and Neil. They have been at the table from the very beginning because the data requirements that SAMHSA imposes, if any of you have had SAMHSA grants, you know what I'm talking about. And for this grant, it's like beyond overkill. So there are medical data that we have to capture, code, and submit. Some of these are quarterly, some of these are semi-annual, some of them are annual. In addition to that, SAMHSA has always got its own unique measure of recovery, so we're taking the NOMS instruments at 0 and 6 months on everybody, and then we have to keep track of the health registry. So at this point in time, we have data set up in REDCap, access database, the EHR, and the track system of SAMHSA's. Neil, did I forget any? Is that right? We got the 4 big ones. And so we're having to pull data from 4 different databases. So I have the entire evaluation team working on this project. We are going to make this work. That's what I had for you today, and I'll take any questions that you might have.
Thanks. Quite impressive. The amount of data that you're collecting is amazing and
mind-boggling.
It is, but here's the but: is you'll be able to look over time in one group, and you might see that people get better, and you won't know if that's because of the program or tincture of time or whatever. And I'm wondering, so to that end, since there's such huge investment going to collecting those measures, is there a way that you could compare to some other folks who aren't getting those services, either because you don't have the capacity to offer the service to everybody, and so you could randomly select people to come into that and compare to those who aren't in it, or some other comparison group so we can get an inkling, make those data even more useful than they might be?
We have had multiple discussions about that very thing. In fact, our initial conversations about integrated care were not about delivering integrated care per se. Is Dossie still in the room? Dossie's gone. We were in conversations with people at VCU 5 and 6 years ago about designing an NIH kind of a project where we would be the location and we would bring in the faculty to work with all the design and the comparative analyses and so forth. They've been going through some changes in their administration and so forth, and so things, and one of the main addictionologists over there left, maybe not as a happy camper either, and went somewhere else. So, you know, there was a bunch of changes that took place that stalled that conversation, and we couldn't wait, and we just said, we got to go after this now. So we're not through with that conversation. There's some new players at the table. We're going to continue that. I agree 100%. The amount of data we're collecting right now should be put to very good use. I support that.
A quick question. Are the patients that are part of this are either patients with serious mental illness or co-occurring disorders, not some primary substance use disorder?
Well, they can have primary substance use disorder too. So I think I said this, we're bringing people in unit by unit, and I'm going to talk geographically. We're going up to the upper 3rd floor first, which is one of the most seriously impaired mental health units, but 60% of those people have substance use disorders, okay? Then we're coming down probably to the 2nd floor where people are primarily identified as women with substance use disorders. And at least 70% of them have co-occurring mental illness. So, you know, it's not easy to split that stuff out. We expect to see more co-occurring cases than anything, but we do have a few clean, if you will, with substance use disorders.
And you have, and what is the percentage of strictly, seriously mentally ill that we treat with this?
It's easier for me to talk about our static capacities in the agency. At any given time, we probably have about between 4,000 and 5,000 open cases, and generally that's about 1,000 substance use disorder, 1,000 intellectual disability, and 2,000 mental health. So that's a rough division within that, but the numbers are not insignificant either way. That's a good question. Anything else? Okay, thank you.
Well, we're on a rolling start here with 2 really wonderful presentations. One of the things you can remember from this is what Carrie said. Remember how you can go back and say, have you heard of value-based purchasing? And now you have all heard of it, right? Yes, yeah, you can say yes. And it seems like both of these approaches are getting people who are capable of swimming in other waters. And in some ways, I think that's what's going to be happening for all of us as the field changes and we get more involved in primary care and the medical system. Our 3rd presentation is by, let's see, in high school, I always wanted to be really popular, you know, and Juli Buchanan, her service has become more and more popular. It's too popular now, she says. Juli is a Chase Braxton program. We got that right here, or just south of here in Baltimore. And we're glad to hear about your model for integrated care.
Thank you. These 2 gentlemen that come before me are hard acts to follow. They've been doing this for a long time. My story is a little different, I think, for what we've been doing at Chase Braxton Health Services. So today I'm going to tell you a little bit about Chase Braxton so you understand kind of the context of how we started developing our program, as well as talk to you a little bit more qualitatively of what it was like to be on the ground, on the floor, so to speak, trying to integrate into primary care with mental health services. So to start, we started off not as a federally qualified health center. We actually started in the late 70s as a gay men's HIV STE clinic, basically. And we really came to be out of the AIDS epidemic. Thank you. There we go. So we really came to be out of the AIDS epidemic, and we started off very much a grassroots organization with a couple of primary care medical providers who were willing to see mostly gay men who had full-blown AIDS. We had literally a couple of medical providers and a case manager in a small little office, and the case manager took a old refrigerator and put it on its side, put a board on it, and that's what he worked off of. And it's literally important, because I think it's important to know kind of the context from which we come, and as we grew and took care and started to develop, I guess, a reputation for a provider that would see people that no one else would, we grew, we added more primary care, we added more case management. Over time, we added behavioral health. Later, we got a great SAMHSA grant to add addiction services. And then later, we actually became a federally qualified health center. We stayed really true to our mission for years and years, with HIV positive being a top thing that we were concerned about treating, as well as we served the GLBT community, and we're very open about that. However, as we grew, we became very aware of the fact that we weren't just seeing GLBT folks or HIV positive folks anymore. We were really seeing, we had broadened, and we were seeing much more of the Baltimore City community as well as Baltimore County. And we were really serving the underserved and people who were not able to find services anywhere else. So we changed our mission, we broadened that, and we continued to grow. So back about 3 years ago, this is really kind of a story of a different way to do things. There were 3 psychologists, myself, I was one of those psychologists. We were working in the behavioral health department. We were seeing patients every day, doing your typical 50-minute behavioral health visit. But we had this passion for integrating our services into primary care. We were doing some health and behavior groups. We were working with patients who had HIV. We were working particularly with patients who were having a lot of trouble with adherence to their medication regimens. So we were doing a lot of that work, but we had this passion. We thought we really need to be in primary care as part of the medical team. But of course, as both Terry and Jim have talked about, the thing you run into immediately is how can you pay for this service? So us three little psychologists who had full caseloads really didn't know what to do, but we started hammering on how can we do this. We had support from our director of behavioral health at the time, who said, well, you can carve out an hour of your admin time when you're supposed to be doing clinical documentation to go meet with the billing people and see if you can figure it out. So we did that, and we couldn't figure it out, and we kept beating our heads against the wall. But we were fortunate that we had leadership who was interested in what we were talking about. We tried to make a business case as best as we could, which at the time, I mean, we're going to talk a little bit more, I'll talk a little bit more about ACA and next steps for us, and how that's actually very helpful for us in building this model. But at the time, there really wasn't too much that we could talk about other than we hoped we would have impact on health outcomes, and we hoped that we could help primary care providers cope with what was already happening in many healthcare systems, and particularly in a community health center, of the pressure to see more patients in primary care, and the pressure to see patients in less time and to spend less time with the patients. And we were already getting feedback from our medical providers and nursing staff and MA staff that they were feeling frustrated and burnt out and unhappy with their profession because they weren't able to provide the care that they wanted to provide, keeping in mind our mission, where we come from. Our medical providers are very mission-driven. They want to help patients. They're not here to make money. They don't think like that. So those were a couple of the things that we went after when we were talking about how we might be able to help primary care. And then the other little piece that we went after was this nasty little figure called cost per visit, which in many FQHCs is too high, and in our FQHC in particular was too high, still is. And this is particularly difficult for us because we work with a really complex population of people that have multiple comorbid medical problems as well as mental health problems. So we kept selling, and we kept saying we really need to do this, and finally we had a little window of opportunity where we were told, okay, well, you can go over and be in the clinic, and you can have one afternoon a week. So we said, all right, we'll take it. And so we rotated, because one clinician couldn't be over there every Wednesday because our productivity would drop too low. So we said, all right, we'll take it. We talked to the medical providers. We said, hey, can we come over? They said, well, we don't really have room for you, but you can come on Wednesday when the clinic is less busy. So we said, fine, we'll come. And that's really when some of the interesting barriers started to present in our rollout. Initially, the medical providers and medical team were really happy and willing to have us, but then when we got there, that's when we started to pick up on, well, what are you guys gonna do? And you're not really gonna do this, are you? Problems we had. You guys don't do that. You're not, you have these nice offices and you do your 50-minute sessions, and how are you gonna do this? And we kept saying, no, here's what we wanna do. We want to be part of your medical team. We want you to be able to do these warm handoffs. And some of the providers knew what we were talking about and said, okay, yeah, we'll warm handoff anxiety and depressed and patients in crisis. And we said, yeah, you can do that. You can hand off your anxious, depressed patients in crisis, which sometimes means crying. And addictions, of course. We don't want to forget that. So, but we're here for more than that, and so we tried to talk to people and say, we can actually help you with the medical problems. We can use motivational interviewing to help people identify their barriers and what's going on for them and where their ambivalence is. We can identify whether it's resource-driven, and that's why they're not adhering to their HIV medical regimen, etc., etc. But it was really a challenge to kind of get people educated. And when we first arrived, just to tell a little story, we first arrived in clinic, they were really cool. They were like, hey, we found this little closet in the back that we're going to make an office for you. And I know it's not as nice as what you have up there in the upper floor, but it's an office for you. And we said, thank you. That's really nice, but we don't want the office. And that really confused everybody. What do you mean? But it's not that bad. Please, just take the office. So we had to say, no, we don't want the office. We want to be part of your medical team. We want to sit with you in your documentation rooms. We want to talk with you. We want to be part of your huddles. Huddles? We don't have huddles. Oh, maybe we should have huddles. So that's kind of how it started. And then we worked with the CMO and we said, hey, we need to get into your meetings. Well, one meeting a month in an FQHC to go over everything with medical providers that might need to be covered. It was hard getting on the docket, but we kept using motivational interviewing and all the skills that we had to get in the door so that we could get some time with the medical providers. And so we worked our way and we helped them understand what a good referral was. A good referral was like, they were really anxious. What do I do? How do I refer a good patient to you? And so we had to say, don't worry about it, just refer everyone. Just hand off anyone that you're having trouble with. We'll figure it out. That was a really huge culture shift because we in behavioral health had been perceived as being these really picky, very controlled, sort of, that's not an appropriate referral. We're not going to take that patient. And we really had to change that culture, and not just in primary care, but in the department itself, so that we could actually increase referrals as well. So flash forward, this kind of worked, and the interesting thing about it is that we hoped to have data. We hoped to look at outcome data to say something about what we were accomplishing. Are we accomplishing something on health outcomes? Are we accomplishing something on mental health outcomes? Are we just ensuring that someone's more likely to show up to their next appointment? But unfortunately, we were having tons of data problems with our EHR. We are now actually moving up to a new version in order to solve some of our data problems. So we have great hope about the future and what we might be able to take a look at. But the interesting thing was just being there one Wednesday a week was enough for enough providers to talk to the other providers, to talk to the CMO, to talk to the CEO, to say, hey, this is really interesting and this is helping morale, staff morale. So much more sort of as Terry talked about, we didn't intend it to be a concierge model, but it kind of turned out that way, where we were supporting medical staff. So really, we really did this sort of in the traditional Chase Brexton grassroots way, without a lot of research, without a lot of analysis of flow and how it was going to fit in with the clinic, et cetera, et cetera. But what we ended up being part of is we kicked off an effort when Chase Brexton decided to build a new, or buy a new building, because we were housing about 4 at that time. We wanted to come together. We kicked off this whole agency-wide effort where then the agency put together a task force and looked at, when we move into our new building, how do we want to set up primary care and how do we want to do that so that we're creating a model that doesn't just include behavioral health, but includes case management, nutrition, lab, etc. And so that kicked off something we call them pods now. I think we really need to come up with a different name, but we actually designed our space in our new building in a horseshoe model. Patients' room in the exam rooms from the outside, the staff sits in the middle, and literally you have a multidisciplinary team, medical provider, MA, behavioral health consultant, case manager, and the warm handoffs are easy and smooth, and the communication is easy and smooth. And so we started increasing staffing. We've continued for 2 years now. We've worked on billing. Jim and I think you and I need to get together to try and figure this out, because my goal is the same. We have to figure out how to sustain this. We don't have sustainability at this time. I'm carrying the salary cost on in behavioral health. So my behavioral health department, which is general behavioral health training, psychiatry, and addictions, is carrying this model. We think, however, when we struggle with productivity, we struggle with cost per visit, and all these things, and there's pressure constantly for more productivity, both in primary care and behavioral health as well, I'm able to hold the line on no, this is working. We need to get the data to prove that it's working, but we need to really be careful about yanking the service, because of course, I have to say it, value-based purchasing, population management is coming, both on the behavioral health side and, of course, on primary care side. So one of the things that's really exciting about what we're doing now is we're working collaboratively. This was so siloed, and we really fought the different silos that existed in our agency. There was behavioral health, there was primary care, there was dental, there was pharmacy, and we're really coming together as a team. And I think in some ways this integrated primary care project that we did facilitated that. Next steps, interestingly enough, I'm currently working with the chief medical officer to actually create bi-directional integration now, and we're talking about actually putting primary care in some of the behavioral health spaces, and even talking about building an addictions pod that's specific to helping people and having primary care, psychiatry, and different people potentially in this pod, so that we're not having to refer people back and forth. And speaking of referrals, the one hard piece of data that I have is that the good news is that we were running about, it's difficult to know exactly what the status was, but when someone would refer from primary care to our behavioral health department, whether addictions or general behavioral health, we were running at about a 30 to 35% follow-through rate. Hard to tell exactly what was up with that because we were in different buildings, and as you all know, in the literature, the farther you have to go, the more time lapse, etc., the more difficult it is to get people to follow through. We're in the same building now, so that makes it much easier. However, our referral rate jumped to 77% follow-through in treatment. So we have to put some of that on integrated care. So that's where we are today, and moving forward. Questions?
So we've got about 7 minutes.
I have one question.
We have a microphone here. It will be in your hands.
So I had a chance to visit Chase before you got into the one building.
Oh, you need to come back.
Okay. And I know that the behavioral medicine psychologists were oftentimes working with, so multiple, they were working with people with substance use disorders, mental illness, they may have diabetes, HIV, so the multiple. And the approach really was that they were working with individuals across the chronic disease or chronic illness spectrum, and really trying to focus on this total integrated process. So, and the hope was at that time that the psychologists would be able to work with people with chronic illness around changing their behavior, so that you might be seeing people with just diabetes and hypertension and didn't have a behavioral health issue. Is that still kind of where? Okay.
Absolutely, and we're doing that. I mean, we do that in primary care with more of a brief intervention, warm handoff, 20-minute intervention type of process. But then there's also the opportunity to refer to more of a, to the behavioral health department, where we can do 3 to 4 sessions of a health and behavior type of approach, where we try and work with people around whatever their issues are health-wise. Again, we don't get any reimbursement for that, so it's a real struggle for us to support it, but we do it.
So more like the changing behavior, the health coaching, that kind of thing. Okay.
Yeah.
Thank you.
And one of the struggles that we've had that I didn't talk about was training, and that's training of the behavioral health consultants, because the three of us were trained in health psychology, but much more like behavioral medicine when we started this process, and we quickly realized none of us were particularly well trained in addictions. And so we quickly realized when we got into primary care that, oops, we're missing something. And so we had to reach from our addictions program, pull someone in that could train us on how to do the SBIRT and how to do different types of interventions around that. And then the other issue that we've had is that it's a very intense pace. And I think in general, not every psychologist or therapist is or likes that kind of a pace or feels good about being in a medical setting. And so trying to help people adjust to that and or combining and creating hybrid situations where people can work in the medical clinic, but then also work in general behavioral health with a more regular caseload.
And then my final question would be, at some point, all chronic illness has a behavioral component. You have to change something to manage your chronic illness. Tobacco use, better exercise, better nutrition. Do you foresee a time when it won't just be behavioral health, or instead maybe behavioral health now encompasses all chronic disease, not just mental illness and addictions?
I think we're moving in that direction, and I think that's there's still a lot of silos in many ways, and I think language is sometimes problematic, and we probably, as a profession, all of our professions, we probably need to try and think about how we change the language around that so that it facilitates that process. But yes, I think that's happening. I think that ACA is going to necessitate more of a movement in that direction.
I would love to see the behavioral component emphasized as a way of managing chronic illness, regardless of what the chronic illness is, whether it's, like I said, whether it's addictions, because then, again, that kind of, to me, is the final, curtain drops around the stigma against behavioral health as it's defined now.
Yeah.
Since you've been here for a while and they are sort of familiar with what you do, what do they say, hey, can you see this patient, we're having trouble with adherence or psychiatric, or what are the targets that they identify when they're referring to?
That's actually a great example. We really struggled with that at first on two fronts. One, trying to help the medical providers understand what they could refer to us, and then how to facilitate communication so that it was quick, because of course they don't have a lot of time. But yes, they literally will pop out of the exam room, grab one of the behavioral health consultants and say, hey, can you go in and work with John? He's really struggling with adherence to his HIV regimen or checking blood sugar or whatever it is. And then that behavioral health consultant will go into the pod, or into the exam room rather, work with the patient, and then come out and at some point try and catch the medical provider for a brief face-to-face conversation about that, as well as write the note, of course. One of the problems that we had at first, going back to stigma actually, was that the medical providers were unsure, very willing, by the way, always very willing, but unsure as how to talk about that handoff. And so they would say things like, I want you to see the psychologist, or I'm going to have the mental health person come in and talk to you about, the problems that you're having with staying on your target, or we're doing whatever you're supposed to be doing. And so, of course, the patient would be like, I'm not crazy, I don't need to see a shrink. And so there was immediately that wall would come up, and the ambivalence to seeing us would be ramped way up. So we spent a lot of time working with the medical providers around language and how to phrase that, and really wanting to be part of the medical team. And that was another thing. We always felt like an afterthought. We were not included in meetings and a variety of settings, and it wasn't intentional. Sorry.
No, I think we have very nice.
Before introducing our final speaker up to lunch, I just want to remind you, we will have time afterwards for discussion. And the questions can't be, can we get out early if we don't ask any questions? So get those questions ready and get everything to say. Perhaps also the speakers can stay and talk with you individually if you don't want to speak in front of other people. But I'm trying to help, particularly people who are here from a treatment setting or a planning setting, to get involved and benefit from this. So our final speaker is Adam Brooks, who's from TRI, the Treatment Research Institute in Philadelphia. He's doing some very interesting work on a number of fronts, including the comic books that you do, or graphic novels, something. Anyway, but he's going to talk with us about brief counseling for substance abuse.
So I'm last on the presentation because I got my slides in last, but I'm actually now glad to be last because there's a couple of things that both Jim and Judy have said, I think, make a nice segue to what I've been working on. So I should say, I can't believe it, the acknowledgement there. This work is funded by the Department of Health in the state of Pennsylvania. They put their tobacco money towards health-related research. So I'm going to actually present a research project that we're doing. It's a pretty large grant that came in to look at adding brief treatment into federally qualified healthcare centers for patients that have illicit substance use problems. So I am more like a researcher, but I play a practitioner on TV. And I'm like Jim May 20 years ago. In the sense that I'm kind of more like in the nitty-gritty of just like what's happening clinically, a lot of what I do. Essentially, this was a project that was funded in partnership with 3 federally qualified healthcare centers that serve neighborhoods in Philadelphia that are low socioeconomic status. The patients are often very multi-problem. They have numerous chronic illnesses. And in addition, a couple of them are actually like attached right onto public housing authority developments. So they get a lot of the patients are coming right out of there. So Rich brought us all down yesterday by telling us how nothing that we're doing works. And in fact, I actually had some of my doubts as well about whether Espert could really work for illicit drug use. I mean, there's some literature that shows that it works for reducing harmful drinking, but could one session really help people with illicit drug use problems? So that's what this study is largely about. We're looking at whether or not could one brief session be enough to help people with a substance use issue. And what we largely posited from the very beginning was that no, you would need to do a lot more. You would need like brief treatment on hand or multiple sessions to help people with an illicit substance use problem. So we're doing it. So our big questions that we're looking at is, will illicit drug users, will they come back for additional sessions? And this was a question that was generated by our community partners who would tell us, look, they don't want to talk to us about this stuff, so we can talk about it with them once and encourage them to go to treatment. They're not going to come back just to talk to us about reducing their substance use. And then the question would be like, is an expanded intervention, if you offer brief treatment, is that cost effective? Would it pay for itself if you did have a clinician that was dedicated to providing that? So we have this grant. It covers a lot of things. It covers implementing the Espert and the brief treatment. It covers doing the large-scale randomized clinical trial. It covers sustainability and cost effectiveness at the end. This is just sort of the centerpiece clinical trial. Essentially what we're doing is we're across these 3 FQHCs, we are screening 5,000 patients for drug and alcohol use. We're trying to identify 1,000 plus harmful users, and we'll take, you can be harmful or a risky user, you can have a mild to moderate diagnosis, you can have a severe diagnosis. We're taking everybody, all comers. And we want to consent and randomly assign 600 either to receive a 1-session brief intervention, your classic Espert approach, or what we call it Espert Plus because it can take different shapes. It can be that initial session plus up to 5 additional sessions of brief treatment that happens right at the agency or at the FQHC, or it can be all of those sessions that are mostly geared towards trying to facilitate a referral into specialty care if the person determines, if the BHC determines that the person's problem is quite severe. And then we're following up at 3, 6, 9, and 12 months to get biological results, interview, how other outcomes that they're facing. And no, Rich, I know you're already wondering, is there a no treatment control? There's not a no treatment control. Right. So, because they wouldn't let us have it, you know. They said we identify these patients, we have to do something. So one thing I should say is the settings that I am at are excellent. They are all already had a behavioral health consultant model in place when we got there. And I'm talking about super individuals who are really dedicated to the health coach model. They were all psychologists or licensed clinical social workers who'd been working at it for at least a couple of years. They knew how to do like briefer contact points. And what I'm really going to talk about here, because we don't have, the trial's not finished yet, we're still getting data in, so I'm going to talk about the barriers we face to implementing and how we solve some of those barriers, and maybe jump to this question that Judy raised of how do you build training and excitement for doing substance abuse treatment in these settings. So essentially, you know, if you're not familiar with the BHC model, the BHC model is that you're doing quicker sessions, you're not doing them in an office, you're typically doing them in the exam room after the medical provider has left or some other shared space on the clinic. What you think of yourself as a BHC is you're the first line of behavioral health that the person will get, because very often people don't follow up on those referrals that you make. So you think, what could we accomplish if I just gave this person 3 to 4 contact points, or 1 to 2 contact points right here in the clinic? What if I can get the person to just shift their behavior a little bit, and that behavior starts to cycle into more positive change for them overall? So you're looking for really, really small measurable steps people can take across a variety of problems. And you can start to help people treat their depression, their anxiety, compliance with medical treatments, that sort of thing. So it's 1 to 4 brief sessions. When I say brief, I'm saying like 10 to 20-minute sessions. And that's what they were used to doing. And then if you can't crack that nut there, you're referring that patient on to specialty care, whether it's specialty mental health care, specialty addiction care. So one of the barriers we faced right off the bat was the existing LCSW said, you know, we already do substance abuse stuff. There's no reason for you to bring your project here. Because it was one of those phenomena of their bosses had applied for the grant, but nobody had told them they were applying for the grant. So they were kind of like, you know, it's okay, we got enough over here. But when we really looked at it, what we found is that they weren't screening. So they were really only intervening with very severe cases. And their intervention was largely, wow, you are very severe, this is pretty bad, we need to get you to treatment. And, you know, and so they were making referrals. You know, and I paraphrase, I mean, it was largely, how do I get you into specialty care? And that's what they thought the project would entail. We started talking about people who had less severe cases, and my saying, you could treat them here. You could actually handle the problem here, and they would never have to go to specialty care. And a lot of them won't go anyway, so wouldn't this be great if you could provide it? We made them halfway believers there, but it wasn't until screening got in place, and they started detecting lots and lots of people with mild to moderate level substance use who had been on their caseload for years, some of whom they had worked with behaviorally, and they had no idea that this person, they'd already had like 3 or 4 behavioral interventions over the course of the year that the patient had in the clinic. They didn't know the person was drinking. So now that person comes up, and they're like, oh, and the little pieces are coming together, and they're thinking, I would like to work with this person here. I don't think they would go if I referred them somewhere else. So when we got them more aware that they could intervene in low intensity cases, that barrier began to change. All right, the other big barrier that we faced right off the bat was they challenged me. You're a psychologist, you're used to working with people in a specialty care clinic, you don't know how we work. And one of them did me the favor of taking me out to lunch and like going, let me tell you about my day. And he actually walked me through what it's like to be, you know, to have very short sessions, to not be sure if you've done enough when you let the person go, but to know you can't be their therapist, you're a BHC, it's brief treatment. And so he and I sat down and I said, well, what I'd like you to do is this. And it was almost like we came to a bargain in the middle of them sort of agreeing they would do something a little bit more extended, but I didn't get everything I wanted and they didn't get everything they wanted. But the other thing that became clear is I had shared with them, like, well, I want you to do some behavior therapy, I want you to do some motivational interviewing, I want you to refer interested people to 12-step, and there was a big knowledge gap. They hadn't had any of this training. They didn't know how to do any relapse prevention work or 12-step facilitation. And so I said, what would be the best format for you to have informational takeaways that you could give to your patients, what would you use? He basically said we have to be able to cover it in 20 minutes max, that's the max, and it has to be bite-sized. And so we took these interventions and we broke them down into 35 very, very basic hot point, how do you just get this information across, how do you make sure the patient understood it, how do you get a little commitment from the patient and then send them on their way type of toolkit. So we built essentially an intervention toolkit that really covers these 5 areas. Psychoeducation, like psychoeducation, how many drinks are in a bottle of this, what's the drinking limit for men and women, what is binge drinking, that kind of thing. Most of the interventions are really built around building motivation for change and making small steps or planning change. There's a lot of interventions around behavior therapy, so some of the simplest stuff that come out of like CBT or relapse prevention that could get people working on reducing their change. And then a few interventions for those who have a 12-step history or what would be willing to try out 12-step, how to get them started going to meetings. And then finally for people that really need specialty care, how to educate them about what you can expect at specialty care, how it's going to be different than primary care, where should you go, that sort of thing. This is an example of one of our education cards we developed. A lot of the patients are smoking marijuana like it is medicine and do not think of it any other way. And this is in a state where it's not, it's not medically approved, of course. And in a lot of ways, while we have a drinker's pyramid, we didn't really have anything that the therapist could sort of reality check patients about the severity of their marijuana use habit. So we took NUSDA data and we put together the marijuana pyramid. And they use this when the patient is like smoking every day, they point out that the patient is at the top of the pyramid. They're like, yeah, it seems like everybody smokes, but not everybody is smoking every day. And so if you're smoking 4 to 5 times a week, you're in the top 2.5% of the U.S. population for marijuana consumption. Now, by the way, a lot of our patients are like, that pyramid cannot be true because I know everybody in my neighborhood smokes. I wish that we had very good data from their neighborhoods to build something that was more keyed into their demographic. And I think that this little thing would go over a little bit better. The other thing that we did is we knew that a lot of patients wouldn't come back. They might only get 1 session, so we wanted to make sure that some of the interventions actually got into their hands and they could take it home and sort of self-start if they were interested in self-starting. So we put together this graphic novel that tells the story of 2 patients with substance-related medical conditions. And it's really based off of, like those pamphlets they can give you if you want to quit smoking, or the NIAAA pamphlet that they give you, like, for reducing your drinking. It's based off that, but it's written at about a 5th grade level. And it tells the story of 2 people, one who has a drug problem and one who has an alcohol problem, who their bigger problem is their medical problem. And their primary care provider says, you really should knock off this substance use because it's making your medical problem worse. So the whole thing is really, and it tells the story of these 2 patients over 7 chapters who start the self-change process based off that advice. But what we do is we sneak in a lot of the CBT and the motivational enhancement exercises that are in that clinician toolkit. They're snuck in here, but they're built in a way that a patient could figure it out on their own. So like, for example, here one of our characters, he's self-monitoring his drinking because he's trying to get a sense about how much he actually drinks. And then you, the patient, can drop down to the bottom of the page and follow his model and self-monitor as well. So we did this largely because our community advisory board, this was the messaging format they thought would go over the best. And it has been, our preliminary responses from the patients are that has been a hit. Patients would come back. We had one patient write a thank you note for the graphic novel. Oh, thank you, that was really nice. I read it in the homeless shelter, and it was really nice to read. We've had patients come back, they come back to their 2nd intervention, and the whole thing is filled out. They've done everything in it. And then the most fun anecdote, early when we first started handing them out, one of the patients came back for the 2nd intervention, and she said, oh, listen, I took this home and my partner uses too, and he actually read the whole thing. And he's out in the waiting room. He has some questions about it. Could he come in and talk to you about, like, he wasn't even one of our clients, but he wanted to talk about concepts that came across to him in the booklet. So that's our, that's one way that we've sort of resolved that. And I think one thing that we try to do, what we try to do is, I'm used to trying to package evidence-based stuff in a format that a clinician will want to use it. My job, what I think of my job is, nobody wants to read a manual. Nobody will read the manual. And since nobody will read it, you have to build materials that they can use that capture the kernels of the manual, so that they will start using those materials before they'll ever read your manual. Then if they use those materials and they start having positive successes, I'm talking about the clinicians, you have made them now more open to better understanding how the intervention works. So I think of it like you go to McDonald's and you look behind the counter and they all have these like, this is what a Big Mac looks like, it's in pictures, you know, and it's, here are the steps to make a Big Mac. It's like that. You know, and because if we don't do this, then what clinicians normally do is just whatever feels comfortable and what they sort of turn their practice into. If we want evidence-based practices to get in there, we have to equip the clinicians with formats that they'll actually use. So I know my time, this last barrier that came up is, first of all, we actually had some management issues. Dr. Weisner yesterday was talking about the MAs were her best friends. They are your best friends if management convinces them that this is their job. But we had a lot of, whose job is this screening thing? I don't know that I want to do it. Isn't that a BHC thing? Shouldn't they do it? And until we got the MAs on board, like, oh no, this is quicker than you think, it's going to help a lot of patients. We had to have several meetings where we actually went back to the MAs and told them the end result of something that they had done with a patient. You detected this problem from your screening. The BHC did this, and now the patient is doing this well. And so we had to get them on board that way. The other thing that we struggled with, actually, the other thing that amazed me, we got very excited because one of the clinic directors got so excited about the screening, she said, no more paper screeners, we're putting this in the medical record. I want to make sure everybody gets the screening. I was ecstatic. I thought, oh, this is going to mean that everybody's going to be asking questions. But one of the things we found out was that direct interview didn't work very well. Our positive screening rate dropped by 40% when people were directly asking the questions to the person, as opposed to them getting to fill it out on a piece of paper and just hand it in. And the reason that we think that part of the reason is because if you think about these locations, a lot of the people who worked in the clinic also lived in the neighborhood. So the MA might know you, or the MA knows your mama, or, you know, and she's asking you these questions, and you don't want to endorse your marijuana issue with her. So we've actually wrestled with that, and we solved it by reintroducing the paper screeners, and then the MA just goes back and enters that in, and that's my time, and I'll be glad to take questions. Yes.
Wonderful. There's a lot of nodding and people that
How do you obtain the comic book?
Well, it's a TRI product, so we put it together in the context of this project, but TRI tries to make everything that they develop available. So if you get in touch with me, I'll give you my card and you can look into it. Thank you. Yeah. So let me say just a little bit more about that. So TRI, we get a lot of research grants. It's all public funded money. So what we try to do is whatever we develop out of those grants, we try to turn it into solutions that practitioners can use. And we have a whole separate solutions department that actually, if you want to use something we've used in a clinical trial, they will try to work with you to make it available. So I'll be, just anybody who's interested in that info, I'll give it to you right after the meeting. I can give you the contact.
So it was kind of interesting to me that all of you sitting up there, one of you Adam was focused on start where the workforce is. One was start where the system is. Another one is start where the program is. And we talk about start where the patient is, but for each one of these integrated efforts, you have to start where other parts of the system were at. It's kind of interesting.
You had a question?
I was just wondering if your study includes people without insurance in Like, are they able to come in with no insurance?
You know, I don't know that, to be honest with you. I mean, these FQHCs are geared to serve anybody. So if they have insurance, they're serving them. If they don't have insurance, they're trying to get them Medicaid as fast as possible. So it's pretty much. And the expert over here is reminding me that they're mandated to have a sliding scale. I could say something about payment too. I don't know if people would be interested. This is one of those things that did come up. They were already generating, so their BHCs were already supporting themselves mostly through their contacts, and they just find ways to bill for this too in the usual channels that they were before. So if the patient's coming in for primary care and they attach a behavioral intervention on top of it, they get the federal wraparound rate. Yeah, okay, which means that they get more money for that visit because behavioral health happened when primary care was happening. If the person would come in for just a behavioral health visit, then if the person also had a diagnosis, it was billable. They could bill that, but I don't know how that was arranged. But I could put you in touch. I could put you in touch.
Yeah, that'd be awesome.
Yeah.
Thank you.
So correct me if I'm wrong, but I think I saw another take-home message, which is that everyone, staff-wise, and maybe even funding-wise, everyone was resistant at first. And then as you push through it, people are happier and more satisfied because they feel the work they're doing is having some positive effect. So I mean, and so it makes it sound like no. There's one here. Yeah, okay. So I got three nods and one no.
No, I mean I think in the hospital setting, I mean there are different settings we work in. In the hospital setting, you know, generally speaking, there's a sense of desperation. So nurses are particularly very, very grateful when someone's there to help out. And the more the better, particularly in the emergency room, which has a very much a hands-on kind of culture. I mean, that hands-on culture, if my peer engagement specialist is, you know, sees that someone needs to be rolled someplace and does that, or somebody, you know, whatever it is, if someone's starting to act up a little bit and can go in and say, hey, friend, you know, they were integrated in very, very quickly. So,
yeah, so you didn't have the resistance.
No, we didn't have that sort of, I think they're different. See, we actually designed, when we were given the money to go into the emergency room, most programs kind of, it's a different stance. We actually went to leadership first and said, as opposed to going to leadership in the ER and saying, hey, here's our program, I need an office to screen everybody, and I want you to, you know, lend me a medical assistant, and you know, it's a burden. We actually went into them and said, what is it that we can do for you? And we're here to serve you. I mean, it was concierge. I mean, it really was. And they said, it was very interesting. They said, recidivism, it was, they wanted to figure out the metrics around cost. Safety didn't come out initially because they didn't understand that. But the director of the ER, the physician, said, and I want you to help me so that triage nurse over there doesn't hate her patients. And so I mean, that was the charge. And then we went forward. So I think it's a little different stance. We really took our consumer, was the staff.
I would say it a little bit differently too. I think that with our experience with two different grants now, with the one being very small, kind of isolated within the organization, people sometimes are either negative about or fearful about that which they don't know and they don't understand. That program was never marketed, it was never drummed up in any way, shape, or form, and so you kind of see something going on over in the corner, but you didn't really know what was going on. And now we've taken a 180-degree approach, and I think internal marketing is a big piece. You've got to sell it to people, internal in your own organization, that this is important to the long-term financial health of the organization. This is important for the health of the consumers that we're serving. And then when we went team by team, we were essentially saying, what would you like us to do? Which is not too different than his comment. So a lot of internal marketing, I think, helps get past that.
Yeah, I would second that as well. I didn't find that people were resistant so much as, excuse me, is fearful. And I think, really, I think that, a lot of willingness actually to help us and to participate and to have us there. They just had absolutely no concept of what that meant. Right. And so, and they wanted to do good by us, but they didn't really, and by the patients, I think. But they didn't know how. And since we were sort of trying to piecemeal this rollout, it was very difficult to actually to do that internal marketing piece in any kind of comprehensive way. So, if I had to do it over again, or if I were going to do a new rollout of something, that would be something I would push a lot harder to try and get more of an internal rollout.
If I could just add, you heard also about feedback. That to staff. We always talk about feedback to patients.
Yeah, that's.
But feedback to staff was actually really important. So we actually strategically made this part of the job function of our peer engagement specialists on the floors. So we said to them, when you find out what the outcome is of someone you're working with, if it's positive, go back to the nurse and tell her. And so we did that. We even had instances, because sometimes folks come into the hospital and they actually come visit, and and we would actually walk them through the clinic, or through the office of the medical floor, and that is actually very, very important, because you have to overcome, which is a generational sense of hopelessness. That these patients just cycle, they're hopeless.
I had a question about presence. So most of you actually are kind of moving inside the system, and you're actually present there. Most of that, though, is brief interventions. And so for some of those people, they need to go to specialty care. I mean, one of the concerns of some of the specialty care folks is, you're going to take our jobs. So you're going to take over. And I wondered how you think about collaborating with, if you're inside, how do you think about collaborating with the specialty care folks? Because are you enough? Is a brief intervention enough? How do you kind of link to the larger care? How do you go to kind of your referrals? And then the second piece of that is, that's going to actually increase costs, right? So how do you sell that? Because now I'm going to get, that's what we found with a lot of the early interventions is, you get people, if you're really working to get people into care, you get a lot more people in care, then the costs go up in terms of overall cost for a system. So those are the kinds of pieces I would be interested in.
Let me just clarify, we are the specialty care provider. The people that we're serving are severe in their behavioral impairment. Right. So we're putting the primary care piece inside of that organization, so I guess we're a little different in that sense.
Yeah, we're primarily a referent. We're referring. Our mission is to identify, engage, and have that person get onto that rope bridge, if you will, that is a community-based care. So the community treatment providers are critical to us, and they actually they're looking to us for referrals. And they're very excited to get sort of these warm handoffs. And we very much need to forge relationships to facilitate that. So we've gone out to each and every one of the major players and met with their leadership teams to kind of problem solve, so that we can cut through some of the nonsense sometimes, and can do really, because it's a hospital environment, it's very fast. our team may learn in the morning that someone's going to be discharged, and so we need to be able to turn around. So there's not been an issue. I think we're in the middle of an outcome study around cost, and the treatment provided to someone in a community-based drug treatment center is much cheaper than the $300 a day plus medical bed. And I haven't had the MICU and all the physician costs and all, so most of these patients, I think of them as big fish. They're big time utilizers, and we don't have to have many of those go into treatment for a short period of time to pay for the whole thing. So, I think the business model will ultimately be fairly straightforward. It's anywhere else but the hospital is cheaper.
Let me just follow up on that piece too. Since we've started this clinic, we've actually been approached by one of the larger hospital systems in our agency. When they got word that we were setting up this clinic, they're now talking about, Virginia does not have expanded Medicaid at this point. Let me say that. So that is a huge barrier for us. What one of these health systems has done is basically kind of create their own version for their hospital system of Medicaid for their non-paying customers, if you will. And they have not heretofore included us on their provider list that would get reimbursed for serving those patients. Now they hear we're setting up this clinic, and they're coming to us and say, maybe you could be a provider in our network if you could start taking some of these people quickly out of the hospital.
Okay, more questions, thoughts, reactions? Oh, there's one, our hostess.
Thank you. So it seems to me, and correct me if I'm wrong, that you're describing a new job, you have a new job description or category called Behavioral Health Specialist. Is that right? And so maybe you can say just a little bit more about that and whether how similar is it to these things that are being called health coaches? Is that the same thing? And where is a person going to be able to go to learn how to be a behavioral health specialist?
So that is a moving target. I think everybody that I came in contact with who was doing this was an LCSW or a licensed psychologist. And I think that, and maybe Mady can speak to this a little bit more, is that they're, to bill for certain Medicaid stuff, you got to have that, one of those two designations. And so actually attracting people into the work, I mean, you know, it can be difficult. I mean, it takes a certain type of person who really wants to move outside of their training. There are some health psychology PhD programs, but not so much from what I gather in the clinical social work schools. So it's a job where somebody comes into it and really learns on the job, I think. Now, if you ask me, we have way too narrow of a window of the type of person that will allow into these positions. I think it needs to expand to people who don't necessarily have to have a license right off the bat, or people with a master's degree in counseling, I think could do just as well as somebody with an LCSW. But that's where we're at right now. So I don't know if you guys want to add to that.
I don't really have anything to add other than I think that I agree with everything that Adam said, as well as I think just trying to, you know, when I looked at different staff members who expressed interest, that was first what I needed to look at, is an interest in trying something new. You have to have a little bit of a sense of adventure, I think, to want to do something like this. And then looking at people that maybe had initial training in brief intervention in general, and skills-based work, and motivational interviewing. And I think that, you know, looking at those qualities helped me find those people.
And I think that the concept of behavioral health specialist is particularly important, like in the FQHCs. They're basically saying, give us somebody who understands behavioral health, because we don't. So somebody that's going to be comfortable working with those kind of issues. So it could really cut across a number of different disciplines and so forth. In Virginia, because you really got to think about how are you going to get reimbursed for it, you're leaning towards licensed staff, whether they're social workers or psychologists, to get reimbursed fully for that. One of the things we're doing with our grant, however, this is the second half of your question, we've been using peers, addiction recovery peers and mental health recovery peers in our organization as paid staff for over 10 years now. And with this grant, we've actually hired one, and we're hoping to hire another one, a peer in recovery, and we're training them how to be navigators to help people find their way around the healthcare system. And it's looking very promising at this point in time.
I think, I don't know if
we have one down here and then over there.
I don't know if people got this from your presentation, Terry, but your peer specialists, right? Those people are peer specialists, right? And they are actually employed by a substance abuse treatment facility, not directly by the hospital. Isn't that right?
Right, yeah. We rent them. But I learned something really important in the alcohol treatment program. I have to tell you, Phoenix House is a therapy community. It's been around since 1967, like many drug treatment programs. None of this is novel. They've been using peer counselors and outreach and drug treatment, for decades. And we basically just co-opted that and put it into a hospital. And we do get from time to time blowback from people that say, well, that person's not licensed. They're not they're not educated. And I'm like, all right, my woman that has a fairly high degree who ran her own ad agency, the other guy ran 2 McDonald's, they're very educated, they have college degrees. Now they've gone on now, and all of these folks are getting high levels of training and screen. But I just learned something more shocking. Petey, the parrot, can do brief interventions. And so,
Did he go to college?
He didn't go to college. So so Petey the parrot can do brief interventions. My folks have learned how to do a more standardized approach, and actually Adam was involved in helping them sort of standardize that, because we were concerned about having multiple sort of ideologies that would interfere, and it hasn't really been an issue.
Does everybody know Petey the parrot? Yes. Okay, good.
Yeah, so I would say that the notion of licensing gets to credentialing, which is a real problem for us, because to be a peer counselor means that you had addiction issues, which means almost assuredly you have criminal justice involvement, because it's almost, in fact, it's almost part, when I interview, we have really interesting hiring sessions, because we can't ask these questions, but they kind of come out. But that precludes you from credentialing by traditional means in a hospital environment. So we've actually had to start with vendor credentialing to get around that, and now we're working with the state to get a special credentialing. But it really, I don't want fee for service, because that's one, it's not getting towards shared savings and what ACA 2010 is all about. I want to go to this other model. And every time someone tells me about, well, you can bill for this with a credential, I cringe, because that's the old model, and it won't allow us to access what really is the important thing. We're not going to get more money to bill. We have to figure out how to shift by savings what is already being allocated to the system. And you can't, and if we have to rely on someone's credential to do that. Now, having said that, I think there's a real role in primary care for someone that can do these higher levels, but that's a different thing.
Really quickly, and then I'll pass this on. I want to respond to Carlo about the fear in the field that, what I think they're, based on what I heard in terms of these briefer interventions, the specialty system that I've known for the last 40 years really has, by design, dealt with the most severe. I think one of the things that the specialty system needs to begin to do is offer some of these shorter and briefer interventions, and not, believe that everybody has to have this long-term, ongoing, forever treatment. So I think, it's going to require some change, obviously, on both sides. I'm passing this to Woody, and then I think Richard has a...
Just back to Mady's comment about your commentary about hitting them where they lie, so to speak. In your hospital system, if you want to try to figure out what might get adopted, it sounds like the top administrators have a major say. They say, this is important, we've got to do something. But then you also talk about the nurses, talking to the nurses in the emergency room. I'm just curious, how those levels interact. Do the nurses talk to the administrators, or, where do you, how do you make those selections, or get some sense of what might actually fly if it was?
Yeah, but they do talk when things go badly. And going badly would be complaints. That they're not helpful. It doesn't take many negative complaints, and how that would play out would be a meeting, senior management meeting, where the director or somebody says, "Oh, how's that project engaged going?" "Oh, okay." Kiss of death. What you want is that person being loudly advocating. Wow, thank God they're really helping me. And you really are marketing for the whole spectrum, and that internal marketing for adoption is critical. So in a healthy system, the leadership is having their finger on the pulse of what's helpful. You just need to be part of the solution to whatever the problem is. Now, sometimes you have to educate people as to what are the problems and what are some of the, it's not like it's completely passive. But it really, it is two-pronged. You have to meet people where they're at, not only on the medical floor, but in the C-suite.
Amen. Real science.
Yeah, thanks. Just to follow up on Maxine's question about behavior, I think she asked about having a behavioral health specialist in medical settings. And we know that patient-centered medical homes are required to deal with a behavioral health issue, and that may be a way that they then can support staff like that. But I want to propose that there's really two issues, or two types of behavioral interventions that need to go on in general health settings. And I wonder if you all, or some of you, have come up against these two types. I think what we need is a behavioral health specialist and a health behavior specialist. Now, it could be the same person, but there are two different functions. One is, my patient needs help with medication adherence and maybe some nutritional advice and something about physical activity in order to improve their diabetes outcomes. The other is that they have a mental health issue, a mental health or substance abuse issue that needs to be addressed, maybe dysthymia, maybe hazardous alcohol use, maybe even addiction. And those are sort of two different things, and I wonder if you have experience coming up against those two. Is it the same kind of people that would do those things? One is way more common, by the way, right? So all these problems are common, but adherence is everybody, and hazardous alcohol use is only 10, 20, 30%. So any thoughts?
And along that same line, which category would you put smoking cessation specialist?
Yeah, both.
Exactly.
That's an interesting question. I have to think about that one a little bit more. I used to teach health behaviors at VCU in the Epi department for 10 years and got into the habit of stealing some of the better graduate students out of that program and putting them over in our agency, where mostly it was psychologists, counselors, and social workers. So then when these public health Epi students were coming over, people were looking at me kind of funny, like, what are you doing? And I think that there's at its simplest level, that's really health promotion and wellness promotion, which is big in the ACA now, and it's about getting people to do more of certain things, exercise more, eat more vegetables, all these healthy things. And all this addiction field that I've been immersed in for a long time is about getting people to stop doing things. So there's a little bit of a reversal going on, and we're trying to figure out how to blend those two. But I kind of like the way you framed that. I think that makes a lot of sense.
Maybe our last question, and then there'll be a chance to catch people afterwards.
I just wanted to comment on yours. A nurse case manager is both. A nurse case manager goes out, works with the SMI and substance abuse population at their level in their homes, as well as takes them to the supermarket, takes them out to exercise, so there's one solution.
A good way to end, I think, our discussion. So, I promised you things to tell people back when you return. You're going to go back to the office or to your desk, unless Terry says they've changed it to something else while we were gone. But anyway, we'll be back on Monday, and they'll say, "Oh, you're back." Or they'll say, "How were things Thursday, Friday?" "Oh, were you gone?" Yeah, I was gone. I was at this conference on preparing for change. I didn't even know we were supposed to. Emerging models for integrated healthcare delivery, and it was really worth the time. It's not just that I got swelled pens, from the outside people, rows of CDs and value behavioral health, and these Post-its that they could give me, and things like that. But there were these really good workshops on how to do brief interventions and how to help people stop smoking and what's going on with opiate users and treatments. And then there were these wonderful presentations. Tom McClellan told us all about how physicians need to learn about this stuff, about substance abuse. And Rich Seitz told us we didn't have to believe anything that Tom McClellan said. And Connie Weisner told us about a bunch of models that we could use, where you can train the physician to be sensitive to substance abuse, or you can instead hire somebody at a different level who doesn't make as much money, who can do the same thing with good effects. And you can also just work with the patients to train them how to use what's available, just like everybody else does, so that they can shop for doctors, or they can lose weight, or just doing the kinds of things that other patients do. Then there were other presentations throughout the day, including just a drop-dead, wonderful panel on models for integrating care with a bunch of practitioners, and we got to ask all the questions we had. So I thank you for coming and to this. Thanks to our presenters. And,
okay, so we've heard a lot. Jim started giving us a summary of what we've heard over this last day and a half. And our last speaker, Mady Chalk, who has been in the field probably longer than I have, maybe, so that's a long time. But Mady has many years of experience in the addiction and mental health field. She used to work with the Division of Services Improvement and the Center for Substance Abuse Treatment, SAMHSA. She is now with TRI, has been with the Treatment Research Institute, I don't know how many years, but 8 years. But Mady has a lot of understanding around what needs to happen next with the workforce. And so she's going to close this out. We asked her to connect the dots, from day one to the end of day 2. So Mady's going to try and give us some key points, kind of connect the dots, and wrap up the day. Mady?
Since I am the last person, we heard a great deal about integration. What we still haven't been able to talk about, and these are the challenges that we're facing, by the way, if we are moving toward integrated care. What we haven't talked about a lot is what do we really, and Rich raised it, what do we really mean by integrated care? And until we get to the point, the 4-quadrant model, which I've seen many times, and you will be seeing many more times, is an academic model that has been used as a top-down way of looking at what we call integration. What it seems to me needs to happen, and I'm saying this especially because this is the CTN and the ATTCs, is that we need to move from the bottom up. Take a hard look at all the people who say, and there are hundreds across this country, hundreds of FQHCs. I dare say I've talked to 100 myself, personally. FQHCs and other community health centers and treatment programs that are doing integrated care. Now, all of them are facing issues in all of these areas, and the reason I know that is that 4 or 5 years ago at TRI, we decided we wanted to take a look at integrated care. And we scoured the country with a group of researchers to look for programs that said we're integrated from states across the United States. And we brought them together. We finally brought 20 to TRI, and we brought the federal government in. We said, this is your chance to tell SAMHSA and HRSA, 2 federal agencies that were most looking at integrated care, what you think integrated care is. You tell us. We're not going to tell you. And out of that, we got a number of lessons learned. Every single one of those integrated care programs focused on these issues, one way or another. Now, at the time we did this, health homes were not on the horizon, but they are now. And if you were to talk to people who are implementing the Affordable Care Act, what they would tell you is that health homes are the highest form of integrated care, in their view. I don't know what that means. I mean, I don't know if you know what it means, but I surely don't. But I want to know what it means. And I think it behooves all of us to try to find out what it means. What is the irreducible minimum core components that need to happen with regard to shared savings, billing systems that are no longer fee-for-service, because they won't be under the ACA. They will move into Medicaid managed care one way or the other, and it will be managed. And if it's managed, it won't be fee-for-service. What does it mean in a health home? Who has the answers to that? Well, CMS, the Center for Medicare and Medicaid Services, will have some of those answers, because they're the ones who are putting the money out for health home innovation grants. Workforce. This whole discussion that we just had here we need to look across the country. I've talked to treatment programs. I was talking to La Raza in California, in Oakland, and the director there, I said, well, what are you doing about your workforce related to integrated care? And she said, well, she's very tough. She said, it's all about attitude. They have to want to be here and they have to want to work in a medical setting. And most people who come from the specialty sector, she said, I haven't got the time to be worried about retraining people who have come from specialty treatment because they can't do it. They can't work like this on a team. They don't know what it means to work at the top of your license. That phrase is what's embedded in what has to happen in integrated care. Working at the top of your license. Working as part of a team. How many people who work currently in addiction specialty programs are ready to be part of a team where somebody else is expecting them to know what to do and to do it fast? How many are prepared not to have their 45-minute sit in your office, do your counseling kind of session? So there are issues to be dealt with. Turf and attitudes are a critical issue right now. I mean, under the Affordable Care Act, things are shifting. Who's in whose turf? Whose job is it? And how are we going to blend those together in a way that we can live with? Leaving aside the whole issue of the electronic health record, which I'm not even going to get into. That's an issue that's sitting in front of all of us. But long before you get to the electronic health record, the whole issue of attitudes on both sides, because this is not a one-sided issue. And it takes time. There are in SAMHSA, as they funded this Center for Integrated Health Solutions, which I think most of you have heard about, there's this notion that if you give them enough TA, technical assistance, and if you give them enough webinars, it'll happen. It takes years for this kind of change. We're talking about a huge sea change, and I think we need to understand, and I think the CTN can contribute to this, understanding better, before we just go lickety-split out there and say, okay, well, we're going to spend 3 years now trying to do something, but we don't know, we haven't got a clue what it is. I think while we're implementing, we need to be studying. Every time there is just to give you another anecdote, in upstate New York, Western New York State, there's an FQHC that has 8 satellites. They are, in my view anyway, fully integrated. What do I mean by fully integrated? Every single one of their sites has a behavioral health type. Is it a behavioral health specialist? I don't know. Where did they get them from? They got them from the community, from people who were doing this and that with addictions treatment. I didn't look at their credentials. I haven't the faintest notion. I only know that they are in all the 8 satellites. The higher level functions, some of what Adam was talking about, where you're going to see somebody over a period of time, is in the main program. Not the satellites. They're all located in a geographic region. They have weekly support calls. They have ways of, they have all the consultation they need, and they use telemedicine where they can't because they're in rural New York, upstate New York, which is where the poorest counties in New York State are. And they have to use telemedicine because they can't get Hispanic workers. So, and their population is largely Hispanic because they're migrant workers. But they seem to have managed to do it. They're the kind of group that I would be interested in sitting down with and saying, what is the irreducible minimum? What is it? What are the functions you are having to carry out? So I think, you know, all I really wanted to say at the end of this, I think what we've talked about takes us to a point where we really need to now take the next step. And the next step needs to be, as all of this is being implemented, and it's going to be implemented, how can we get out there and study it as it's being implemented? So we've come to understand much better what the elements of integrated care are, whether it's in a hospital setting, in a primary care setting, in a federally qualified health center. All of the models are going to be different. They're all going to have to deal with these issues. But they're all going to be different. They, sooner or later, over the next several years, we will be able to boil down all the differences into some commonalities. And it seems to me that's where we need to head with all of this. So I'll just stop there and let you get on with your weekend.